special guest. Her name is Raquel Bennet. So I will introduce Raquel in just a minute, but briefly, I just want to go over some guidelines about how this will work. So first off, so this is open to the public, and we are actually recording the event so that the conversations and the questions in the presentation can be available online to those that couldn't attend afterwards, and as well if you want to go back and watch the recording if you felt like you missed anything or you want to take some extra notes. So just to let you know that if you feel uncomfortable with your identity being disclosed or your face, you can always turn off your video and you can actually change your name. If you go to the Manage Participants little icon, which is the two little heads at the very bottom, you can basically hover over your name, and where it says More, it'll give you an option to rename yourself if for whatever reason you don't feel comfortable with your name being displayed on the recording. And if everybody could keep their videos off and their microphones muted, and any questions that you have, please put into the chat section of the Zoom meeting. So for those not familiar, again, at the very bottom of the application, there's a little menu and there's a little chat box. It looks like the little ... when someone's sending you a text message in writing. So if you have a question for Raquel or for myself or just something in general, then go ahead and type your question in the chat box and we'll get to that afterwards. And so the way this is going to go is that Raquel's going to give a lecture that she gives about her ketamine research, and then we'll open it up for questions and answers. And I will say that while most things are fair game, and we'd like to keep things related to ketamine this week, please don't ask any questions about how to source any illegal compounds or where to find underground therapists. We do try to keep this whole movement above ground. And so, you know, just keeping in line with that, we'll try to make sure that we only field questions that are aligned with those values, but otherwise, most questions are fair game. So let me introduce our special guest, Raquel Bennet. She's a clinical psychologist and a ketamine specialist from Berkeley, California. She primarily works with people who are living with severe depression, bipolar disorder, and/or suicidal ideation. She is fascinated by the antidepressant properties of ketamine and has been studying this for over 17 years. She also has a long-standing interest in the psychedelic and mystical properties of ketamine and the potential for this medicine to be used for spiritual exploration. Dr. Bennett is the founder of Kriya Institute and the organizer of Kriya Conference, which is an annual and international event devoted to understanding the uses of ketamine in psychiatry and psychotherapy. You can learn more about her work on her website, which I will link in the chat box. But for now, I will turn it over to Raquel and she can get started with the presentation. So everyone join me in welcoming Dr. Bennett to our Ask a Psychedelic Scientist meeting.
Hi, everybody. I'm here. You can wave hi. Oh, gosh, a lot of you have your video turned off, so I can't see you waving, but I'm just going to assume that you're doing it. Nice to meet you. Nice to see you. Let me start my slideshow for you. Give me 1 second. Let's see here, and then I have to get the Zoom share on. Bear with me, we'll get there. Okay, let's see here. Come on. How's that? Does that work?
I can see that, yes, thank you.
Okay, fantastic. So I'm really excited and honored to be here. I'm Raquel Bennet, and as Jessica said, I'm a ketamine specialist. I've been studying ketamine since 2002. Let's see, I'm gonna not look at the chat for now because that's gonna be really distracting, but please feel free to put your questions in the chat, and then Dr. Nielson will feed them to me when we finish the presentation. Let's see here. So I would first want to make sure I express my gratitude and thanks to Dr. Nielson for having this space and for inviting me to talk with you today. It's such a wonderful offering where we can all come together and share our ideas and learn from each other. Thank you. So anyway, I'm just gonna launch right in. As you know, I'm in Berkeley, California. For me, the topic of ketamine and therapeutic ketamine is really personal. I wandered into ketamine treatment back in 2002, so 18 years ago. And I thought to myself, dang, this is interesting. And it seemed to have some antidepressant effects, this ketamine stuff. And people around me said, no, that wasn't possible. So my interest in this topic, arose naturally even before ketamine was recognized as a rapid-acting antidepressant. And so I'm happy to talk more about that later. And I thought, somebody should study this, and nobody was studying it. And the next thing you know, I decided I was going to learn all I could about this topic. And my interest sort of snowballed into a fascination and is now a full-blown obsession with therapeutic ketamine. So that's the truth. That's how we got here. I want to be clear that I'm not allowed to administer any kind of medication. I'm a psychologist, and I work in collaboration with a group of medical professionals. And I don't have any financial conflicts, so that means I can say basically whatever I want. Okay, moving on. Here's what I think I'm going to be talking about today. By the way, I think I'm going to talk for about an hour. Let me put my clock on so that I can keep track of the time here. Okay, good. And so here's what I think I'm going to cover. I want to talk about some different ideas about how to work with ketamine to treat depression. That's my specialty. And then I want to talk a little bit about when ketamine is clinically indicated or what it's useful for. And then I want to get really clear on the legal status of ketamine. There's a lot of confusion about that, so I'd like to address that today. And then if there's time, I want to talk about Esketamine, the new expensive filtered ketamine nasal spray. And I want to talk about why it's so expensive and what that's all about. So that's on the agenda. And then after that, we'll take some live Q&A. All right? So anyway, here's the basic overview. Here's the main things you need to know when talking about ketamine. There's a lot of confusion about ketamine and a lot of myths and misconceptions about it. I'm going to try to clear all that up today. So ketamine is a beautiful, sacred medicine, in my opinion, that has some really prominent and promising therapeutic properties. And so I want to talk today about the use of ketamine in a supervised and safe environment, because that's what we do. So here's some things to know. Ketamine is totally synthetic. It's made in a lab. There is no natural analog. There's nothing that we've ever found in nature that does the exact same thing that ketamine does, which is quite interesting. And it was developed in the 1960s as a human surgical anesthetic. So if anybody tells you that it's a horse tranquilizer, just roll your eyes, because that comes out of Nancy Reagan and the Just Say No campaign from the 1980s, but that in fact is not the case. It's developed for humans. And it's a glutamate modulator. It works on the glutamate pathway in your brain and in your central nervous system. So glutamate is a really important neurotransmitter, and it's important for learning and memory and movements. We don't talk about it a lot when we think about mood. We talk more about serotonin and dopamine and all that jazz. Glutamate is a different neurochemical and a different pathway, and ketamine is primarily active in that pathway. So it turns out, like I said, ketamine has some very rapid-acting antidepressant properties that I think are context-dependent. It has to be used correctly in order for it to really work well. But it works in like less than 10 minutes, and that's remarkable. It has a little bit of an uplift, and it also has some mood stabilizing properties that's both calming and sedating, but also energizing. And that's unique to ketamine, so we'll talk a little bit about that. So here's the thing, as you probably know, the reason that you're probably here is because you know that ketamine has some really profound dissociative and psychedelic properties, mind manifesting properties, when it's used correctly and when it's used in a particular dose range. When I say dissociative, what I mean is that the person feels a sense of distance from their own body or from their own sensory input. And as those things are quieted down, the imagination opens up, and ketamine can be very visual and very beautiful. So we can talk about that, but one of the misconceptions about ketamine treatment is that people often mistakenly think that all ketamine treatment is in the psychedelic dose range. And that in fact is not the case. Most ketamine treatment for depression or for PTSD is sub-psychedelic. It's under the psychedelic dose range on purpose. The clinicians often want to avoid invoking or inducing psychedelic experience in the clinical patients. So we'll talk more about that later. But I want to just be really clear up front that not all ketamine treatment is psychedelic. And just to say that it's a really flexible tool. There's a lot of ways to use ketamine. Well, I'm going to go into detail about that. Lots of different routes, lots of different dosing strategies, lots of different ideas about how to use this tool. And it's useful for a lot of different kinds of challenges and problems. And so it's a very flexible and a nuanced tool. And I think that's what makes it so interesting and exciting to study. Moving on, what I'd like to do, I don't know if any of you have heard some of my recent talks through MAPS and online. I often start by talking about different paradigms of ketamine treatment. In other words, different approaches to working with ketamine in a psychiatry or psychotherapy practice. So I'd like to start there today because there's a lot of disagreement in the field about what is the optimal way to work with ketamine. And I think all the different strategies have value, that different things work well for different patients. So what I'd like to do here is outline for you a couple of different approaches to working with ketamine. And it's useful to notice that there's 5 variables in ketamine treatment. There's a couple things that the clinician can change, or some parameters that we can adjust to meet a patient's needs. So the things that the variables that we can work with are the routes, how we're getting ketamine into the patient's body, the routes, the dose, how much ketamine we're giving at any given time or in a single session, how much medicine do we administer, how often, the frequency, how often are we going to do this? We're going to talk about that. The setting, it turns out, you probably know this, it turns out that the setting is a critical variable in the use of visionary or sacred medicines, and one that's often underappreciated, but it turns out that the setting has a big impact on the success of the treatment, it seems. And finally, the other thing where there's disagreement and disharmony and different ideas is when we start talking about something called clinical presence. Clinical presence refers to, it means how does the ketamine provider, or how does the medicine provider, how do they understand their job? What is it that they think they're supposed to be doing while the patient or the client is receiving ketamine? So let's get into some of these things a little bit more. Let's unpack it. By the way, can you see the whole screen, or is the right side cut off? You're okay? Yeah, okay, great, thanks. So, right, before I launch into this any deeper, let me just pause for a second and just check in about the routes. I think I mentioned that there's a lot of different ways to get ketamine into a patient's body, or a lot of different ways that a person could get ketamine into their body. And so here I've made a list of some of the different options. But the thing that most people don't know, there is a critical piece of information. And the thing that most people don't know is that the different routes have different bioavailability. And so bioavailability means the amount of medicine, when you put it into your body, how much of it makes it to the target organ to do the thing that it was intended to do. So when we talk about ketamine, what we mean is when you put ketamine into your body, or when it's administered, how much of it makes it to the brain? That's really the question that we're asking when we talk about bioavailability. And the thing is that the different routes have different bioavailabilities. They're not all equivalent. So if you put ketamine into the body, or many medications into the body, into a vein in an IV infusion, probably 97% of that makes it to the patient's brain. So that's pretty efficient. And similarly, if you give the patient an injection of ketamine, which is not very hard to do if you're a trained medical professional, probably 93 or 94% of that makes it to the patient's brain. So that's high bioavailability, and that's a good thing. Here's where people get tripped up. When somebody puts ketamine up their nose, so through the nasal route, whether it's by prescription or in any other context, probably only 40% of it makes it to the patient's brain. So the bioavailability drops, the efficiency drops substantially. So 100 milligrams by injection is not the same as 100 milligrams up the nose. Most people don't know that, but it's important for what we're going to talk about. Similarly, if you have the medicine put into a piece of candy, when it's custom compounded into a lozenge, that also probably has around 40% bioavailability. So only 40% of the medicine actually even makes it to the brain. And in fact, that number is even a little misleading because it varies by the person and by the day. And so in reality, only 25 to 60% of the medicine actually makes it to the person's brain. So we estimate it at 40% because that's an average. But here's the problem. The problem is that there's this huge range of effect. You can administer 100 milligrams to the patient in their mouth, and they may have gotten 25 milligrams, they may have gotten 60. This is a real problem from a clinical perspective because you don't want the dose to be so variable. This is a huge problem and makes those routes to be really kind of unappealing. Anyway, this list is in decreasing order of bioavailability. So you can see that the most efficient is IV and the least efficient is across the skin or transdermal. I'll leave it there. I just want to plant that seed in your mind so that you can become an educated consumer and really understand this field. I mentioned earlier about clinical presence. Here's the thing, there's so much disagreement and confusion about this. Some ketamine providers really focus on medical monitoring. In other words, really focus on keeping the patient physically safe. And usually physicians or clinicians who work in this way are using a lot of equipment that like beeps and stuff. And certainly all ketamine providers should be attentive to the medical safety of the client. But that isn't the only way to do this. There's some other things to know. Other kinds of providers really emphasize something called psychedelic sitting. It comes right out of the underground tradition. And the idea there is that as a sitter that you're supposed to be as unintrusive as possible and just kind of sit quietly and radiate love and provide a gentle, supportive, loving presence. You might take some notes. But in essence, as a sitter, you're trying to not interfere too much with the client's experience, and you're kind of taking a step back and letting the client lead. So I want to contrast that with a different way of working with ketamine, which is ketamine-facilitated psychotherapy. So what makes ketamine-facilitated psychotherapy, I think, can really only be done by somebody who has some psychotherapy skills and probably some formal training in mental health and has a variety of techniques that they can use. And ideally is done where the client and the provider know each other pretty well. Hopefully they've been working together in psychotherapy for a while. And so it occurs in the context of an ongoing psychotherapy relationship. And the provider has the skills and also has permission to help the client explore their internal psychological landscape under the influence of ketamine. So the other thing that's important to notice is that people who offer true and genuine ketamine-facilitated psychotherapy, they're not just using ketamine to help the patient, but rather the ketamine is just one portion of the treatment plan or the strategy. So I really want to distinguish psychedelic sitting as a separate offering from ketamine-facilitated psychotherapy. And it's really important for clients to understand what service the provider is going to provide and to understand what they're paying for and why they're different, and really be knowledgeable about the services that they seek. Jessica, can you put your video back on so that I can see you? And that way I know if things are going well. Okay, great, thanks. All right, moving on. Okay, so here let's get into it. Let's talk about a couple of different concrete approaches to using ketamine to treat depression and other psychiatric indications. So this has some application to ketamine for self-exploration also, and we'll get to that later. But first I want to talk about the ketamine infusion protocol. So this is what it looks like. It's a patient getting a ketamine infusion. You can see that in the picture. And so here's the details of how we're doing that. When a provider is working in this way, what they're doing is they're providing exactly 0.5 milligrams per kilogram of body weight of ketamine in an infusion to the patient. You don't need to know that. I'm just telling you, just to be complete and comprehensive here. But here's the thing: this way of working with ketamine is designed to be sub-psychedelic on purpose, because providers who work in this way and researchers who work in this way, they believe that the psychedelic effects of ketamine are an annoying and problematic side effect to be avoided. They're trying desperately to avoid that. They don't want that. So the idea is to give the patient a little bit of ketamine in a sub-psychedelic dose by infusion. But the problem is that it's just simply not robust enough most of the time to have a really profound effect for a patient who's depressed. So to get around this problem, providers who work in this way, what they do is they ask the patient to come back 6 times. They sell the patient an infusion series. So typically the patient comes back 3 times a week for 2 weeks, or a cluster of ketamine infusions like that. And the idea is to make it cumulative, to put more ketamine into the patient's body before the last dose wears off. And in that way, using this divided strategy, the idea is to get enough ketamine into the patient's body to do the magic thing that ketamine does, but specifically without inducing psychedelic experience in any individual session, because that's bad in this model. Let's see here. Yeah, this is fundamentally a medical or a surgical model that focuses on biochemistry and on the biochemical effects of ketamine and on what ketamine is doing at the site of the receptors and the proteins and the chemicals. Here's the problem. The problem is that in this model, the patient is considered passive. They're forced into a passive position. The patient isn't actually required to do anything except to show up for the appointment and then passively sort of sit quietly and receive the infusion. And that is probably a pretty good model for some kinds of medical treatments. But I have a concern or a question about whether that's the best way to help somebody who's having a chronic mental health challenge. I actually think it's better to empower patients to do as much as they can. And so that leads us to a different model. Oh, I have another thing I want to say. Hang on. Before I move on, I also want to just mention again this Esketamine nasal spray, this new product that was approved by the FDA about a year ago. It's called Esketamine or Spravato, made by Johnson & Johnson. And this nasal spray follows a similar protocol to the one I just described with the infusion. It's low dose nasal spray. You have to come back 6 times. It's designed to avoid psychedelic experience. And there's no psychotherapy that's required. There's no attention to that in these models, in either of these models. And I think that's problematic, frankly. So let's contrast that with a different approach to working with ketamine. So it's the same medicine, it's just a different set of values, a different set of priorities when you do ketamine-facilitated psychotherapy. So in this paradigm, in this way of working with ketamine, the idea is to use the ketamine as a lubricant for the psychotherapy process or for the talking dialogue, the exchange. So in the previous model with the nasal spray or the infusion, there is no talking. There's no concurrent therapy, that's not valued. But here the emphasis is actually on the dialogue, on the therapeutic conversation. So here's how you do it. You would do this in a psychotherapist's office probably, and most commonly it's done with a lozenge or it's like a piece of candy that has ketamine put into it. Sometimes it's done by injection, but again, you want to keep the dose pretty low if you're going to work in this way, because when patients get too intoxicated with ketamine or have too much, they're no longer able to concentrate or talk. And so that you're trying to avoid that. You're trying to keep the dose low or moderate. And people describe this as generally pretty relaxing, and often people describe it as pleasant, even when they're depressed. Part of that has to do with the setting and the relationship. But it sometimes enables people to talk about material that they weren't able to get to otherwise in regular therapy, either because it's shameful or because they were afraid. And sometimes this really helps to open up the work and the conversation. And then sometimes people have access to material that they really need to get to. So this is fundamentally a relational or a psychological model that really emphasizes the verbal metabolism of psychological material. And what I like about this is that in this kind of model, we do this quite a bit. In this kind of model, both the patient or both the client and the therapist, they're working together and they're each contributing 50% of the effort. They're both working pretty hard. Trust me when I tell you, I'm working pretty hard. The patient and I are working together in a collaboration on the patient's behalf. And I like the idea that the patient is being asked to show up and fight for themselves and do some work, hopefully that they can take with them that has a lasting effect. The challenge here, of course, is that psychotherapy can be a slow process. It's not instantaneous. It takes time and it takes financial resources, and the insurance coverage for this is, spotty. And so that's one of the drawbacks, I think, of this approach, is the cost and the investment of time and money. Oh, I wanted to add this. So when you administer ketamine to a person or a mammal, what happens is the presence of the ketamine sets off a chemical cascade or a chain of events that results in dendritic sprouting. And what that actually means is that the tips of the neurons in your brain start to sprout and they pop out like this, and they make connections to other neurons. New pathways are actually physically being formed as a result of ketamine exposure. And it probably takes 2.5 days for that to happen, we think. We're still studying this phenomenon. But anyway, the reason I'm bringing this up now is because the presence of ketamine opens up what appears to be a neuroplastic window when learning is more potent. And so that would suggest that that's the optimal time to do psychotherapy when it really kind of gets in there. And that's what we observe clinically with people, is that the psychotherapy that we do with ketamine or immediately following ketamine treatment does appear to be very profound and potent. It's almost like it's getting hardwired in. And so I think that's a good reason to combine ketamine treatment with therapy. Of course, my goal is to help people to identify their own triggers and to learn new coping skills so that they're not dependent on medication forever, but rather that we're able to make lasting psychological change. So I think that's an advantage of this approach. Okay, and then here, now this is the part you were waiting for. I can tell you're excited. Now we get to psychedelic ketamine. So this is again the same medicine, but it's a different paradigm. It's a different set of values, a different set of priorities. It's using the same medicine. And yeah. And I just want to say for the record that you should not lie down in a body of water while under the influence of ketamine, in case that wasn't obvious. It's metaphorical, it's not literal. You don't float on ketamine. I still like the picture and I'm keeping it, but I just wanted to make sure I said that. Okay. That's what it's supposed to feel like, but don't actually do it. All right, here we go. So here's the thing. When you're working with ketamine in the psychedelic dose range, here, what's different about this than the other things that I said is that here the clinician is purposefully inducing or inviting psychedelic experience, inviting non-ordinary visions on purpose because the clinician and the client together believe that that might be helpful, beneficial, or valuable. And so in order to do this, so here now you have to work in a slightly higher dose range. You have to work with roughly 1 to 2 milligrams of ketamine per kilogram of body weight. bioavailable. So if you do it by injection, it's not that hard to do. It's much harder to do with nasal stuff or lozenges because as I said, the bioavailability is not so good. We do this also in our practice. We've been doing this for years. The person who taught me how to do this has been doing it for at least 30, maybe 40 years. Yeah, it's a long session. It's a long day. The patient is going to be with me probably for at least 4 hours and maybe more. And essentially, I just want to pause here and say that we select patients very carefully to see who's appropriate for this approach. Not everybody is a good fit for this, but when a patient is correctly selected and when they are correctly or carefully prepared, you got to do those things first. Then we would go on to have a psychedelic ketamine session for them. And when you work with the ketamine, what happens is that the patient is launched into about an hour, maybe a little bit more, hour 15 of sort of pre-anesthesia. They're partially immobilized. They're having very vivid, colorful dreams. It's very psychedelic. And that's the intent of this kind of session. But as I said earlier, not all ketamine sessions are like this. This is only when you're working in the psychedelic dose range. And so this is fundamentally a shamanic or a psychedelic perspective. Again, there's a couple things that make it shamanic. One of them is that the visions are valued. They're thought to be essential to the treatment and not an annoying side effect, but rather the main action. That's part of it. Part of it is that that patients often or clients often report that they see that everything is connected when they're in this space, and that really comes out of a shamanic worldview. And then you can work with those ideas. The challenge here, there are a couple of challenges. It's important to be able to keep clients medically safe and psychologically safe. I don't think we give enough attention to those things. And this frankly would not be safe or appropriate for lots of clients. And in fact, in my practice, only about 1 in 6 clients who are interested in ketamine treatment are actually a good candidate for psychedelic dosing. So it's a lot lower number than you might think. One of the things that distinguishes therapeutic ketamine from recreational ketamine, I get this question a lot, is that I believe that all medicine journeys contain information for the journeyer, and often there's an actionable step embedded in there. The actionable step is something that the journeyer or the client can do that they need to be doing in their daily lives to help move themselves toward wellness. And so when you're working with a skilled therapist or guide, part of their job is to help the journeyer identify the actionable step or steps that were in the journey. The message from the medicine is what I mean. And then help the client to implement that in a realistic way. So yeah, I could go on and on about this, but I just wanted to mention that that the therapeutic effect is not just the journey, but rather what you do with it, what you do with the information afterwards. It's kind of like integration. I also just wanted to emphasize that that having a safe container for something like psychedelic ketamine work is really important. And the container has 2 elements. Part of it is the setting, and part of it is the relationship. I often think of people and their minds like Jell-O. You put a little ketamine in, or you heat up the Jell-O mix or whatever, and things get kind of loose. And if you pour the Jell-O into a container, a nice container, you might end up with something really beautiful, like this Jell-O mold here that you see on the screen. But if you don't have a container and you just pour the Jell-O out anywhere, you're going to have a big mess on the counter and on the floor in your kitchen. I can guarantee you that. And in fact, that's what you see also with ketamine, is that when people don't have an appropriate container, a relationship in a safe setting, it can be a big mess. And so I would advise using caution in that way. Anyway, some some things that come up really commonly, that there are a few things that people report so frequently from their psychedelic ketamine journeys that it's worth mentioning. And before you ask, I know somebody's going to ask, how is the ketamine doing that? And so I'm going to tell you the answer, which is I don't know. Nobody knows. But anyway, here's some of the things that come up a lot. Clients who are working with psychedelic ketamine often use different kinds of language to describe their experience of being in the presence of God or experiencing divine or supreme love. So I don't know exactly what to make of that, but it sure does happen a lot. And clients also often get excited about the realization that everything is connected. In other words, the oneness of everything. That comes up a lot. Yeah, so ketamine is a funny little chemical. It's unlike MDMA or psilocybin or LSD, which are all serotonergic. Ketamine actually kind of sort of temporarily makes you forget who you are and like what happened in your history. All of that sort of seems like old news. And it just seems a whole lot less important. And so when somebody is like perseverating on something painful from the past, ketamine can sometimes ketamine treatment can sometimes help people let that go or just like get some distance from it. And so that's unique to ketamine and these other dissociative chemicals. And so that's what I mean in this slide, people moving away from their sense of self, but in a way that can be really positive, helpful. It's temporary. Also, people working with psychedelic ketamine often have the realization that deep down at their very essence and at their core, that they are well and they are fine and they are not damaged, they are whole, and that wellness is possible. And when people are very depressed, sometimes they forget that or lose touch with that, and ketamine can help them remember. Oh, and then this comes up all the time. People report a lot of space travel, planets and stars and cosmos and stuff. Again, how is it doing that? No idea, but it sure does come up a lot. Anyway, let me just recap what I've said here. In the last little bit here, I'm just checking the time. Okay, good. In the last little bit here, I have presented to you a couple of different ways of working with ketamine to treat various psychiatric and psychological disorders. And in one approach, I was really emphasizing using ketamine as a pharmaceutical intervention, using it as a medication for its chemical properties. And then we talked about the use of ketamine as an adjunct to psychotherapy, as a catalyst or a lubricant for psychotherapy. And then we talked about ketamine, using it as a psychedelic agent and using it to induce visions on purpose. So here's the thing. I get asked all the time which of these approaches is the most valuable or which is the right way to do this. And the answer is that all of them work and that all of them are valuable and useful some of the time, but none of these approaches are a good fit for everyone. And so I really think that the competent ketamine provider understands the spectrum of ketamine services, the different ways of using this tool. And the educated client also understands that there's a spectrum of services, that ketamine treatment can look a couple of different ways, and it knows how to ask questions to figure out what service that they want and what service they want to pay for and why. Let me just pause for a quick second and Jessica, how are we doing? Should I keep going? Feeling good? Is anybody falling asleep? Okay, stick your tongue out, give me the raspberries if you're really, okay, no, we're all right. Great. Okay, let's continue on. So people often ask, how do you know what to do? And here's the thing. I'm a psychologist by training. If we can get the job done without using any medicine at all, I'm totally into that. I like to have a light touch when it comes to suggesting or making a referral for medication. And sometimes medication is really needed. And so when that happens, then we should definitely make it available. And for me, my guiding principle is to always use the least amount of medication that we could possibly use to get the result that we want. So yeah, so we always kind of start low and then we swing up as needed. But that's what we're aiming for here, is to minimize the amount of medication that people are taking. Okay. So why would you do this? Good question. Let's see here. So ketamine has been used for, since the 1970s for a whole variety of medical indications. And it's FDA approved for anesthesia and analgesia. And so here are some things that it's used all the time for routinely, and it's all totally legal and all that good stuff. And just in the last 10 years or so, we've come to realize that that ketamine is really useful for a number of things, specifically in psychiatry. So here's the big five. Ketamine is clearly useful for people who have severe and refractory depression. That means that they're really depressed and they're not getting better from conventional treatment. So for major depression, we would consider adding ketamine in. We would also consider using it when people have physical pain with depression. And those two things often go together. So ketamine is really useful because it treats the pain and the depression at the same time. It turns out that ketamine is also really useful in treating bipolar depression. And that's a really difficult thing to treat. You often can't use SSRIs or conventional medication for that. If you're going to do that, the patient needs to be stable or consistently taking a mood stabilizer or an antipsychotic medication to make sure that the ketamine doesn't give them too much lift. You don't want to push them into mania. But when you're using a mood stabilizer on top and then ketamine on the bottom, you can sometimes like catch a person or kind of help them be in a more normal mood range. It's really useful. Ketamine also appears to be really useful in treating true obsessive compulsive disorder, also a very difficult disorder and hard to treat, but ketamine has good results in treating that. And finally, ketamine is really amazing at treating something called ruminative suicidality. And I want to talk about this for a second because there's a lot of confusion about this. Ruminative suicidality is when people obsess on self-harm thoughts despite having treatment, and they find it distressing. So they don't want to be thinking about hurting themselves, but they feel like they can't help it, and it's like intrusive. So I want to distinguish that from being suicidal in response to a stressor. Ketamine is probably not useful for that, and probably not appropriate for that either. So if you're feeling acutely suicidal all of a sudden out of nowhere because something really terrible is happening in your life or happening around you, I don't think it's appropriate to give a medication for that, and it's probably not going to work. Ketamine's usefulness is really limited to this phenomenon called ruminative suicidality. It's recurrent and ongoing over time. It's chronic, essentially. Anyway, there's a lot of literature that supports this. It's really exciting. Then there's a couple of things that the community of ketamine clinicians is looking at as possible uses for ketamine, but where there's been a lot less academic research. So these are considered the investigational uses for ketamine. So ketamine might be useful in treating eating disorders, or disordered eating rather. It's probably helpful in treating geriatric depression, so depression in older people, which is way underdiagnosed and undertreated in this country. It can be very helpful as a last resort for youth who are severely depressed or suicidal. I don't like to give medicine to a growing brain, but if the kid is really in bad shape, then this is worth a try, and there's some research on that. It turns out that ketamine also is really useful when there's death in the clinical picture. And that means that the client is thinking about death, either their own death or mourning the death of a loved one or anticipating the death of a loved one. Because ketamine treatment in the psychedelic range, it mimics death. It mimics a sense of your spirit being separated from your body for an hour. It's like a temporary, safe way, safe when done correctly, a safe way to experiment with that and explore that terrain, and it can be really fruitful in therapy. And finally, a lot of people think that ketamine is useful for personal exploration and spiritual growth. And certainly it does lend itself to that. The question is that legal? Are you allowed to give a controlled substance in the absence of a clinical diagnosis. And that's a tricky area. We can talk about that today. So it's something I think that it's currently considered investigational because of the legal parameters. Then there are some other things that people are looking at, but I want to advise people to be cautious about this. There's some question as to whether ketamine is useful in treating addictions to other substances. Here's the thing, there's a couple papers about this, but in all of the research, the ketamine was given with medication management and psychotherapy in a controlled environment. In other words, the patients were locked up, is what I'm trying to say. And there's a question as to whether we could replicate those findings in an outpatient setting. And the answer is I don't know, but ask me next year and I'll get back to you on this. But it's something that is actively being looked at. It's really quite interesting. Also, using ketamine with anxiety, patients with prominent anxiety, that's tricky. Depression and anxiety often go together, but here's the thing, ketamine is a little bit sedating, but it's a little bit stimulating. And some patients with anxiety report that they feel helped by ketamine treatment, but at least 50% of them find ketamine way too agitating and stimulating. It makes them temporarily worse. So I don't think ketamine is the best tool for this job. I think as we have other psychedelic medicines available, like psilocybin and LSD, I think those are going to be more useful for treating anxiety. Right now, ketamine is all we have, but we should be using that cautiously. There's also some evidence from individual clinical practice that using a little bit of ketamine in ongoing psychotherapy is really helpful in treating some of the personality disorders or chronic relational problems. I'm not meaning to say that you can, take someone like Mr. Trump and hook him up to an infusion and that'll like fix his narcissism. There's no evidence of that. Oh, sorry, am I allowed to say that? But rather that using ketamine in the context of psychotherapy may help speed up the process a little bit and move things along. And finally, the treatment of trauma. Gosh, this is a complicated topic and I could easily talk for an hour just about that one thing. But here's what I want to say. It is a really bad idea to give a dissociative chemical to a person who has experienced dissociative trauma. In other words, if people felt like they were coming out of their bodies at the time that something really horrible happened, you do not want to replicate that with a dissociative chemical. Bad idea, don't do that. MDMA is a far superior tool for that kind of issue. There are other kinds of trauma, and sometimes when trauma and depression go together, sometimes ketamine can be helpful for that, but that needs to be done really carefully with a lot of thought on the part of the clinician. So it's something that needs to be done with caution. Again, it's a big topic and more nuanced than I can get into today, but just want to give you a heads up about that. Let me check and see where we are in terms of time. We're doing pretty good. Let me switch gears a bit and talk about the legality of ketamine. There's a lot of confusion about this. And the source of the confusion is that there's actually 3 different agencies that have a say about what's legal in this country. Most people don't know that. So the 3 agencies are the DEA, that has the schedule of chemicals, the FDA, they give approval for different indications to say that something is effective and safe or not. And then the State Board of Medicine or the State Board of Psychology, who issues and regulates your license if you are a medical or mental health professional. So typically, these 3 agencies agree perfectly, they overlap perfectly in how they understand various medicines, but they don't agree perfectly when it comes to ketamine, and that's where the confusion, that's the source of the confusion. So it is totally not correct to say that ketamine is a legal psychedelic. That is not in fact true. That's going to get you into a lot of trouble. Ketamine is allowed to be used under certain special circumstances, and let me lay out what those are. So these are the criteria that have to be met in order to not get in trouble with the board. The Board of Medicine and the Board of Psychology and the BBS, the Board of Behavioral Science, they are notoriously more conservative than anybody else. in the state. And so you don't want to get into trouble with them. You don't want to have your license audited. You don't want to have your license pulled. That means that, you know, all that money and time that you spent on your education is, you know, for nothing, down the drain. But anyway, in order for it to be okay to administer or prescribe a controlled substance like ketamine, it has to be clearly clinically indicated for a diagnosable disorder that's causing impairment. The patient has to have had previous attempts at previous treatments. There has to be academic literature that supports what you're doing. And the clinician has to be practicing within the scope of their license and training. So if those criteria aren't met, then it is not okay to work with or prescribe a controlled substance. So this is really, I think, where we get into this is really where the challenge is in terms of using ketamine for psychospiritual exploration, is are patients meeting these criteria so that the clinician can be safe? Again, I could spend a whole hour talking about this one slide. I'm not able to do that now, but I just wanted to bring to your attention that this is a nuanced subject that really requires some deep understanding. Another thing that I wanted to say is that when we talk about ketamine, and when we talk about most visionary medicines, there's often a lot of attention on what is medically or physically safe. We give not enough attention to psychological safety. Is the client, is the journeyer able to handle the situation that they're going to find themselves in? And what can we do to help people be more prepared for an experience that is as intense as psychedelic ketamine? And again, I would love to spend an hour just on this one slide, but just to say that safety really has at least two dimensions that we should be talking about. Okay, I'm going to just touch on a couple of other quick things as I try to bring this home, wrap it up. So a new phenomenon is using ketamine at home. And I have to tell you honestly that I have not been a big fan of patients using ketamine at home by prescription to treat their own depression. I have not been a fan of that until recently. But because of COVID and coronavirus, I actually think that doing your own treatment at home is a better option than going in for infusion or injection. I think everybody should be staying home temporarily in response to this, you know, global viral pandemic. And so it really brings up some interesting questions about the safety and efficacy of using ketamine at home. So let's just touch on this real quick. So, you know, using ketamine at home, ketamine that you've either gotten by prescription or acquired in some other way, here's the thing. So it's certainly less expensive than having in-office ketamine treatment. And I think that's an advantage for patients. And I like the idea that patients can take the medicine when they need it. So rather than having to make an appointment and wait 3 weeks for the provider to have an opening, you can just like do it yourself. And I like the idea that patients can be, you know, are able to manage their mood and their medicine. I think we should be empowering patients to do as much as they can for themselves. Here's the problems. There's some risks though associated with unsupervised ketamine use. So the problems include the possibility that the patient or the client may have a scary experience. I certainly have heard lots of examples of that. That's worrisome. If you give patients access to ketamine, you don't want them to become dependent on it, taking it too much. There's always the possibility that it could be diverted or used by somebody else or used in an inappropriate way. There's also the possibility that the patient could hurt themselves. I've heard of this, people falling down the stairs or something while under the influence of ketamine and, you know, breaking bones and being quite injured while intoxicated, even with a low dose of therapeutic ketamine that they're using on their own. So that's a concern here. It would be terrible if somebody hurt somebody else. God forbid someone was decided to operate a motor vehicle while under the influence of ketamine. That could have a terrible consequence for the community. I don't want to see that. I'm worried about that. And it's also possible that a patient could die. I've heard of a couple of drownings where people got into the bathtub and forgot to come back out while under the influence of ketamine, or fell into a pool or whatever. It's unlikely that the ketamine by itself is going to cause someone's death, but rather ketamine in an unsafe situation could result in someone's death. And that's really very worrisome. So we can mostly prevent or avoid these things by having people come to the office and we can supervise them. Having them use ketamine at home creates some new problems. And I think we should be worried about this. Let's see here. So now we come, I'm gonna get off of that and talk just very briefly about esketamine, or filtered ketamine. So I'm gonna just change the subject a little bit. Here's the thing, I've been talking this whole time about generic ketamine, or racemic ketamine, which is dirt cheap. It's a medical supply. It's easy to acquire if you're a medical provider. And it works well for depression and for pain, as we've discussed. So for a number of years, many pharmaceutical companies have been trying to create a derivative of ketamine that they could patent. I should preface that by saying that generic ketamine, the kind that we use in our practice, it's off patent. And what that means in reality is that many drug companies are allowed to manufacture it. So nobody owns the individual rights to it. That's what patenting is. And so because lots of different companies make it and distribute it, the price is really low. It's off patent. Generic ketamine is off patent. So nobody really makes any money from manufacturing and selling medical supply ketamine or generic ketamine. But anyway, when it became clear a few years back that ketamine had antidepressant properties and that was a new use for it, the pharmaceutical industry got really interested in creating a ketamine derivative that they could patent, which is a fancy way of saying they wanted to make money off of it, and they were not able to make a new molecule that worked as well as ketamine worked. That's a whole long story. And so Johnson & Johnson, what they did is they decided to take ketamine and they filtered it. They ran it through a filter. They patented the filtration process, and they came up with something called esketamine. So esketamine, it's hard to, I don't want to go too deeply far down this road. Just believe me when I tell you that esketamine is a filtered ketamine product. And here's the part that you really need to know. I guess I have one more slide that I forgot about. Okay, here, let me tell you this. Generic, I was trying to work my way up to a crescendo there, and then I kind of missed the mark, but that's okay. Generic ketamine, racemic ketamine, the cheap kind, it can be used off-label for certain conditions, as I described earlier, and the prescriber, the clinical team, has complete control over the route and the dose and the frequency. With esketamine, this new filtered ketamine product that got FDA approval last year, it can only be used under certain conditions, and the patient must be taking one of 4 antidepressants in order to qualify for esketamine treatment. And Big Pharma controls how much and how often you're allowed to get it, and it's sub-psychedelic. So it's just important to understand that there's a lot of politics and economics behind all of this. But now we get to the part that I really wanted to show you. Right, so make sure you're looking at your screen right now. Filtered ketamine, courtesy of Big Pharma, $850 per dose. Generic ketamine, the way that I do it, the way that we've been doing it for decades, $1.59 for 100 milligrams. So if you, yeah, right, I know, I can see your eyeballs popping. That's an appropriate response to this horrible news. Right, and so all of this is driven by economics and power and profit, and it's really appalling. And that's why I took the time to explain this to you, because it's important for clients to ask for generic ketamine. And if they're not getting that, ask the provider, why are you giving me this filtered medicine when there is no evidence whatsoever that it is clinically better or different than the old generic product? I'm going to say that again. There is no evidence whatsoever to date that suggests that the more expensive filtered product is in any way better or different than the existing cheap generic product. And it's essentially a marketing ploy and probably a fraud to be selling you this. And so we need to be talking about that. It's outrageous as capitalism and commercialization comes into the field of sacred medicine. Don't get me started. I start getting hot because I get so upset. Okay, moving on. Oh, I wanted to mention this before we stop. There's a lot of different things that cause or look like depression. And it turns out that ketamine is really good at treating some of them and not very helpful for other causes of depression. And so if you're feeling depressed, or you know someone who's depressed, or your loved one is depressed and you want help for them, it's really important that they get assessed or diagnosed by a really qualified and experienced mental health provider to first figure out what the heck is going on and then choose a treatment that's likely to be helpful. So again, I could easily spend an hour on this one slide. Unfortunately, I don't have time for that right now. But just to say that depression is not all the same. And you have to come up with a treatment plan that's going to be effective for your understanding of what's really going on. Finally, for all the patients that I've had hundreds who have gotten better, including ketamine treatment, and who have gotten well and stayed well over time. They're not just using ketamine alone, but rather they're using ketamine as part of a comprehensive or integrative treatment plan that has many elements. And so I've listed some of the elements here that people sometimes need to do. But folks often need to get on a sleep schedule and go to therapy, and exercise is really important. Learning to meditate can be really valuable, etc. and so forth, in addition to ketamine treatment. Ketamine alone is not enough. It's simply not powerful enough and not effective in treating these various disorders by itself. So I'm kind of famous for saying that ketamine should never be more than 1/10 of the treatment plan. And anybody who tells you otherwise, I wouldn't trust them. They're trying to sell you something. But look, here's the thing. Many of these different elements are free. You can do them yourself. I'm all about the free. You know, what can we do to get patients to do the most that they can on their own? I don't want your money. What I want is for you to feel better. So I am in no way advocating ketamine as a standalone treatment. And so if you want some further information, here's some good stuff to look at. I have a website with all kinds of free stuff, yay free, books, articles, videos. There's a link to all my favorite journey music. If you're a ketamine provider or you want to be, there's a supply list and some assessment scales for you and a bunch of clinical forms. If you're looking for a qualified ketamine provider in your geographical area, there is a free list on my website that you can make use of. I also have a mailing list if you want to hear when I'm speaking again, and also a link so that you can send me an email. So I think I'll stop there. As I said, all that stuff is free. So let's, Jessica, if it's okay with you, why don't we take some questions? What do you think?
Yeah, that sounds really good. Thank you so much for that great presentation and for just also, lending your expertise to us, and also for providing some of the realities of what this actually looks like, and kind of, increasing and upplaying the benefits while also downplaying some of the hype and whatnot. I really like your ketamine is 1/10 of the plan. That I think that's a good thing to keep in mind, as a lot of people think of, psychedelics in general as this magic bullet. And, that's very rare that any single thing will fix all your problems, even though psychedelics are good and ketamine has promise. So I will ask some of the questions that have been submitted already, and I'll just sort of shout them out in order and you can respond. And again, for everyone listening, if you have additional questions that you'd like to ask Raquel, go ahead and type them into the chat box and we'll get to them. Okay, so the first question is, I'm curious why ketamine is legal while psychedelic drugs are not. From what I understand, ketamine could potentially be addictive and it has many side effects comparing to safer substances like psilocybin.
Yeah, great question. Let me just get myself oriented here. Okay, well, it sounds like there's multiple questions in there, so let's pick it apart and let's take one at a time. So the fact that ketamine is currently legal is really a historical artifact and comes from the fact that it was developed as a surgical anesthetic for humans in the 1960s. And so nobody really appreciated the fact that it was psychedelic or antidepressant until more recently. But in any case, ketamine is used as a primary surgical and procedural anesthetic all around the world, and used a lot in rural clinics when other kinds of anesthesia isn't available. So that's why it's legal and useful. The fact that it is also used for, used as a visionary medicine, and that we're looking at it in psychology and psychiatry, that's all relatively new. So anyway, that I don't know that it was anybody's master plan for it to be that way. That's just kind of how things evolved. So that's how I can answer that part of the question. You know, the politics of why other substances are not legal is all about, in my opinion, is all about the history of racism and mind control and attempting to control the way that people think. And so that's why various substances have been outlawed, and we could go off onto that. But anyway, the thing is that they really can't make, the government really can't make ketamine, they can't remove it as, they can't reschedule it. They can't put it into a more restrictive schedule because of its importance as an anesthetic agent. So that's part of it. Okay, what was the rest of that question?
The rest of the question, well, it was just sort of related, like compared to the side effects of this, like potential addictive side effects.
Yeah, let's talk about addiction for a second. That's such an interesting question. That there's a lot to be said about that. So first of all, so anything that is short-acting and pleasurable or that reduces pain has the potential to be addictive for sure, because people, might seek that experience for sure. I get that. But in general, ketamine is actually not considered very addictive, and the reason for that is that it's really it's not dopaminergic enough. Things that are more dopaminergic, like cocaine or even heroin, which has a lot of opioid activity, those things, they cause you to have some sort of altered experience, and then with a heavy crash on the tail end. And ketamine doesn't seem to have that crash on the tail end. On the contrary, people seem to feel pretty good after ketamine exposure. It doesn't have a big hangover. So we don't think of ketamine in a medical setting as being inherently addictive. It's not super addictive, and you never see that. You never see pain patients who got ketamine in an orthopedic surgery who then go out and try to get more ketamine from their from a dealer. It's just not a phenomenon that happens. That said, certainly people can become addicted to ketamine, especially when it's freely available or it's unsupervised. But I think the question that we have is whether that's a property of the object or the person. What I mean to say is that a person can be addicted to anything. You can be addicted to video games or sex or exercise or television. So that doesn't mean that those objects are inherently addictive. It means that the person is having an addictive relationship to something. And we think of that as a problem that needs to be addressed within that person. But lots of people enjoy sex or going to the gym or watching TV without becoming addicted to it. And I think that ketamine is probably in that category. It can be the object of addiction, but I don't think it's inherently addictive. Or, I've been doing this for 18 years, and that's not what I've seen. So I guess just to summarize, I think that clinicians need to be careful about ketamine addiction in the community, but I don't think that ketamine is nearly as addictive as some of the other substances that are out there.
Great, thank you. The next question, which I think is pretty important, and I know people in our local community could benefit from this, given all the ketamine clinics that are popping up that are run by anesthesiologists. So this is related to ketamine aftercare, and what is being done to call the field to support aftercare and integration of ketamine experiences?
Oh, yeah, this is a great question. So what's happening, let me take a historical perspective. What's happening right now in the field of therapeutic ketamine is really the convergence, or maybe even the collision, of three different fields that have kind of bumped into each other. So there's ketamine and anesthesiology, so ketamine for pain and sedation. There's a lot that happens in the treatment of depression that comes out of psychiatry and psychotherapy. And let's also make sure that we mention the underground guides, who really have the most experience in dealing with altered states and visionary medicines. So what we're teaching now in therapeutic ketamine really borrows from all three domains: anesthesiology, psychiatry, psychology, and psychedelic medicine. So anyway, this is problematic because anybody with prescribing privileges, which includes all physicians and nurse practitioners and stuff, they have the ability to prescribe ketamine, but they don't necessarily know anything about differential diagnosis or integrative care. And so this is a systemic problem that we're kind of working on, and we're trying to, another agency is trying to create a certification program for ketamine providers to prove that they have competency to use this tool. In the meantime, while we're waiting for that to get up and running, it's really incumbent on the client to find appropriate psychotherapy skills. Now, there's no good reason why you need to see an anesthesiologist for this. We're not working in the anesthetic range, where that's a higher dose range than therapeutic ketamine. And if you're getting ketamine treatment, you need to find yourself a psychotherapist or find one online or an integration group or something to make sure that you're adequately supported in making sense of these experiences, but also getting the most juice out of it. The best part of ketamine experience is the integration afterwards and really working with the message from the medicine.
Great, thank you for that. Next question is, one, do you facilitate group sessions with ketamine? And if you do,
Yes.
what are the goals of the session, and when and how is ketamine implemented in a group setting?
Yeah, you guys need to just take my training, because these are juicy questions with long answers. Yes, so here's what I've learned about group ketamine. I love group ketamine. I love group ketamine because it brings the cost down for all the participants. So yay that, yay accessibility. So not everybody is a good candidate for group work, and particularly if the client is working with trauma, heavy trauma and depression together, probably they're going to be better served by having an individual provider who can give them undivided attention. So again, a part of it is picking appropriate candidates. But for group work, yeah, we do a 7.5-hour long day that involves a check-in or an opening circle, and then some ceremonial aspects to really honor the sacred tradition of this medicine, and then ketamine administration, which then has an hour of active medicine, followed by another hour of sedated recovery or quiet time, followed by a meal, and then a closing circle. So part of the reason that we do it that way is that we are required as providers to supervise patients directly for a number of hours after ketamine administration to make sure that they're safe. So we threw that meal in there as a way of like filling up the time while we have to supervise people. But we didn't realize when we created this, we didn't realize how valuable the group interaction was going to be, that people make new friends and they feel connected and supported, and socially they realize that they're not alone. There's something wonderful about eating and coming down together, and we're not taking medicine, obviously, just to be clear, but people, in a group ceremony that involves medicine and food and talking, it's really lovely. So I'm a big fan of group work, and I hope that more providers offer this going forward.
Great, thank you. This one just came in. I'm kind of going to bump it up to the top because I think it's really interesting and relevant given COVID-19 and you recommending maybe right now people do ketamine at home. And so the question is there a way to treat patients remotely as a virtual clinic if they have their own ketamine?
Yeah, absolutely. Yeah. What you want to do is you want to find a psychotherapist. I think this is what they're asking. Now that telehealth is a big thing, you can see any mental health provider in your state. So what you need to do is hop online and use one of the resources to find a therapist who's knowledgeable about psychedelic integration. And so the competent and ethical provider sees you for a couple of sessions to get to know you a bit and to know what you're working on before getting started with ketamine treatment. But then you may have some ketamine treatment at home. And there's two different models for that. Sometimes the patients take their own ketamine just by themselves and then report back later to the provider. And other times the client and the provider are together on Zoom. So it's a little bit depending on the client and also on the dose. And then there's follow-up integration online. So anyway, if you're in California, I'm happy to give you resources for my students and colleagues who are providing these services. They're fabulous. If you're in another state, you're going to have to, get on Google and find someone. I would look for psychotherapy, psychedelic integration, and see who pops up.
Thank you. As a follow-up to that, do you know of anyone that is licensed to do telehealth in other states than their license?
Oh, that's a great question. Okay, so, it's my impression, I'm not 100% on this. It's my impression that the CDC just relaxed the rules about this. It used to be that you could only practice in the state where you were licensed. But I think that now physicians are allowed to practice across state lines during COVID. And I think that doctoral level psychologists are also allowed to practice across state lines, in which case you can see some of my, my students and my colleagues. It's not totally clear to me whether that rule also applies equally to MFT therapists or social workers. I don't know.
Mm-hmm.
And again, this is changing very quickly, so the information might be different tomorrow. But anyway, again, I think a little Google research would help clarify that.
Great, thank you.
I just want to add that there's a lot of wonderful experienced ketamine providers, and you most certainly should, before hiring someone or agreeing to work with them, you should ask about their experience, the depth of their experience and their training with respect to ketamine. Ideally, you want somebody who has psychological skills and is attentive to medical health and safety, and who's comfortable working with altered states of consciousness. So you can ask outright about all those things.
I guess as a follow-up to that, do you think that the providers should have had experience of themselves with ketamine?
Absolutely, yes. I think that they should. That's a little bit tricky. This gets back into this legal issue. So for me, I've been taking ketamine for depression for 18 years. That's not a secret. And I use it as part of my maintenance strategy to stay well. And that's how I came to be interested in this. So I'm in the clear. I've been taking ketamine. I've had hundreds of ketamine experiences in my life. And most of what I know about being a provider and a teacher and a mentor comes directly out of my experience being the patient. So I guess what I would say about this, there's sort of two places to look. One of them is at psychoanalysis, which is the highest level of education you can get as a psychotherapist. In psychoanalysis, it's required that you undergo your own analysis to have experience being the patient as part of your training to become a provider. And I think that that sets a good precedent that we should be thinking about with respect to visionary medicines. I do think it's really valuable to be the client before becoming a provider, for sure. The other place we can look is in a shamanic tradition where you have to be apprenticed for years to a provider before being qualified or recognized or respected as a healer yourself. I think we should be looking to that too. There's wisdom there. That said, it's not clear that it's totally legal to have your own experience unless you meet the clinical criteria. So I don't want to advocate for anything that's not legal. That's a bad idea. But if it was somehow legal, if you could get experience in a legal way, I highly recommend that ketamine providers have their own personal experience with ketamine and that they're open about that as part of their training.
Great, thank you. Okay, so I have a question related to, so here in the state, we've had this issue where some of the police will instruct EMTs to give people ketamine to sedate them if they're going into the emergency room, and then they have to sedate them if they're in cuffs or something, and there's been some respiratory failure associated with that. And so, that's obviously an issue. And there's also emergency rooms that are administering it for acute suicidality. And so do you think there's like in those cases where maybe, I guess this is a two-part question. I'm kind of like inserting my own question on top of this question because there's sort of this issue of this kind of being administered by people that maybe aren't trained to do it.
Yeah, so you're violating my people who are doing that. That's bad. And here's why it's bad. I can answer both questions at once. Because you're violating my rule because you haven't done appropriate patient selection and you haven't done appropriate patient preparation. Okay, things are going to go badly if you don't do those things. So I do understand that that emergency personnel, or I've read that emergency personnel were using ketamine darts, tranquilizing darts, to sedate agitated people. That has nothing to do with what I'm doing. I mean, like I'm not in favor of that. So you know, that's just giving ketamine a bad name. What can I say? And then in terms of the ER, I don't think it's a great idea to give ketamine to a patient where you don't have a connection with them. The environment is noisy and stressful and chaotic. You don't know anything about as a provider, you might not know anything about their psychological or medical history. So those are all kinds of red flags for me. Yeah, so that's not what I'm about. I'm about relational medicine and the idea that, as I said earlier, you assess people carefully and you select them carefully and give them treatment that's likely to work for them, customized, individualized, thoughtful treatment. And you spend time in preparation, getting to know each other. And then you might introduce sacred medicine if it seems appropriate. So that's what I'd like to see happen going forward.
Okay. Yeah, thank you for clarifying that. Let's see.
Oh, and integration, I didn't say that part, but just to be complete, and that there's follow-up care. You don't just give ketamine and then like abandon the person, but rather you continue to meet to, as I said, suck the marrow out of the experience. So those are the 4 critical steps: patient selection, patient preparation, sacred medicine experience, and then follow-up care.
Great. So do you see any correlations between the feelings of oneness with ketamine, like having a mystical experience, and the improved or long-lasting benefits?
Yes. Thank you for the question, whoever asked that. Yes. Here's the thing. How do I explain this? This is such a great question, and I'm glad it came up. Here's the thing. The thing is that we don't have adequate tools in clinical psychology to study the long-term effects, the long-term beneficial effects of sacred medicine experience. So this is a gap in the field as a whole. But I can tell you from my own experience that I remember like it was yesterday, the early experiences that I had with ketamine, and I'm still chewing on it, and it's still meaningful and informative to me. And we have no way of capturing that data as psychologists. It's too expensive, you know, and logistically complicated to collect that information. But I certainly have patients who, years after their psychedelic ketamine experience, that they still report that those experiences were some of the most influential or informative experiences of their lives. Now, of course, in those cases, we did all 4 steps. The patient was selected carefully. The patient was prepared carefully. We did sacred medicine in a safe context, and then there was follow-up care. So we did all that. But anyway, yes, ketamine experience can be very profound and influential, as with many visionary medicines. But it's sad that we don't have good quantitative data about this.
Yeah, that was going to be my follow-up was, do you think, well, there was a question about can people achieve these states on lower doses, and, you know, what is the threshold? I know that there's like you know, they titrate to dissociate, or you try to get the psychedelic experience. So do you think there is a very strong linear sort of relationship between dose and whether they can have one of these mystical experiences?
Yes.
What do you think that threshold is?
Do I even need to elaborate on that, or can I just say, yeah?
You can just say yes, but I wonder what the threshold is. Where's the inflection point?
Yeah. Well, we think that it varies from person to person, so I'm hesitant to give a hard number. But the entry to the psychedelic dose range with ketamine is around 1.0 milligrams per kilogram of bioavailable ketamine. That means 1 mg per kg made it to your brain. So let me just give you an example of that. I weigh about 200 pounds, give or take. That means that I weigh about 88 kilograms, I think. And so probably around 90 milligrams of ketamine is sort of like the entry to the psychedelic range. But it's not all about psychedelics, right? It's all about giving the patient what they need at that moment. And so some people really benefit from something subtle, something that's barely perceptible, but that helps their depression. And other people really benefit from like 0.75 mg/kg in a lozenge and then talking to you and working something out. And it's a little bit, people are altered. They're like gently intoxicated, but they know who they are and they know where they are, and they can move around and they can talk to you at that dose. But sometimes that can give a beautiful effect. For other people, they need the full-blown wham bam to Pluto and back, the full thing, but it's not appropriate for everyone, and it's frightening for some people, and certainly not appropriate outside of a relationship container. And so I'm hesitant to say that I don't think that that's the golden chalice. I think what's really beautiful about ketamine is the fact that it's flexible in dosing. That said, some people really get a lot out of psychedelic ketamine in the 1.0 to 2.0 range, but that's not a beginner's dose. That's not a good place to start. That's something that, that you would want to, let me put it a different way. A shaman who mentored me in the past told me that a good way of learning about psychedelics was to first learn to meditate, to first learn to observe your own mind and take a witnessing stance, and then to begin to work with MDMA. And then after that, to work in supervision with psilocybin. And if you were still interested in psychedelics and exploring your own mind at that point, that then you might be ready to try something that was longer acting like LSD. And finally, after you had done all of that, meditation, MDMA, psilocybin, LSD, and not in one weekend, by the way, but like over years, that at that point you might be ready to try something like injectable ketamine. So I say that to say that people make the mistake of like rushing in too quickly, and ketamine doesn't like that. I often liken working with ketamine to dating. And so I tell my own students this, that when you meet someone for the first time, ketamine or your date, that it's nice to just get to know each other a little bit with coffee, but you don't want to make a big commitment. You don't want to actually have to stay for dinner, but you just get to know each other. And then if that goes well, then in your next meeting, you might have a meal together. And if it really goes well, it might end with a kiss, and you kind of work your way up, 5-date rule. Eventually you may end up in bed together and have a very intimate experience, but things generally don't go well if you start there. I mean, I don't know about you, you can do whatever you want, but there's a progression. And so I often tell my students to just like slow down and calm down and like try to date the medicine and get to know it a little bit, make friends with it. So anyway, I say all of that to convey that I think it's a mistake. I think it results in harm when people rush in too fast to the higher doses of these powerful mind-altering tools, and rather it's much better to be spacious with it and take time.
Great, thank you for that clarification. Let's see, I'm going to pick maybe something less scientific here. Let's see.
By the way, Jessica, am I getting myself into all kinds of trouble here? Because
as long as you're saying stuff you feel comfortable with. I don't think you're recommending anything illegal or anything.
No, I like to just keep it real. This is what I really think. So, okay.
Okay. So I guess because you have experience doing group ketamine therapies, this question might be interesting and kind of borders the realm of like metaphysical potentially and scientific. But do you have any thoughts on phenomena of people taking ketamine together and entering the same K-hole?
One of my colleagues is tremendously interested in this phenomenon. I have not been a participant in very many group ketamine journeys. I've often been the provider or the sitter or part of the staff is what I mean. So I haven't experienced this myself, but I do have a colleague who is studying this, where you have like 5 clients or journeyers in a room and they all end up in the same place. And when they come back, they report that they had a shared vision. And it's just fascinating. And they're not speaking at all, so I don't know how they're doing that. And I have no idea what this means. I don't know how or why this is happening. I do know that it's a reported phenomenon. Yeah, gosh, if you know anything about this, please write to me and tell me what you know, because we would love to learn more. But yes, I have heard of this before.
That's really fascinating. Is it just through the subjective experience or common objects that they reported on? Like, how did you determine that they all were kind of in the same place?
No, so I've seen it a couple times in my own group, but I've also heard about it through my colleague who has been studying this. But people are just sometimes. I'm getting excited, then I can barely talk. Let me slow down. What I mean is, people often whip out their notebook and take notes during the recovery phase or just after their active medicine. And so they're writing in silence about just capturing what they learned or what the message was or what they saw. And then people often share and compare notes during the meal, and people read from their notebooks. And it's fascinating when people all saw the same thing. They were in the same landscape together, or they got the same message, or someone appeared to 5 different people and said the same thing, etc. And I don't know what to make of that, but as I said, it has been reported. It's quite interesting. And it does seem to happen more with ketamine. I don't know if it happens with other medicines, but yes, ketamine can do that. I don't know what it means.
That's fascinating. Thank you for that. Let's see. You may or may not want to answer this. You don't have to. You can just say pass. The question is, because you had talked about having ketamine experience, and the question is, have you tried other psychedelics? And if so, how does it compare to ketamine?
Yes, I have tried lots of other psychedelics in my life. And I'm allowed to say that because the statute of limitations has run out, and enough time has passed. It's far enough ago in the past, enough time has elapsed that my lawyer says I'm allowed to talk about it. So yay that. But anyway, I was in the care of a shaman in my early years, many years ago, who introduced me to a variety of psychedelic agents to try to treat my depression. And the only one that was really helpful was ketamine. In fact, I talk about this in detail in my interview with Mike Margolis. And so if you want to hear all the dirty details of all the other drugs I've ever taken, you can hop on my website, and the interview is up and it's available for free. But basically, I have had experience with other medicines: MDMA, psilocybin, LSD, GHB, PCP. I'm trying to think if there's anything else that I can remember. That's all I can remember right this second. And the only one that I really, the only one that has any therapeutic potential for me, and the only one that really sings to me is ketamine. I like it because it has this mood enhancing effect with a tail that lasts about 2 weeks after the ketamine exposure. That helps me to function better. So that has caused me to be fascinated with this, and I'm essentially monogamous with ketamine at this point. And I make fun of my friends who are polyamorous with all that, doing all kinds of different things on different weekends. That's too complicated for my brain. But I would describe myself as being in a deep relationship with ketamine. I think of it as an ally and almost as a friend. I use her with great respect and restraint. I only use her very occasionally. I don't use it recreationally or frequently. How does it compare? Well, all the serotonergic agents, all the things like LSD, psilocybin, MDMA, they've got a couple of, they have a few unique properties. So first of all, the serotonergic agents, the things that are active in the serotonin pathway, what they have in common is that they're like a psychological magnifying glass, and it becomes easy, or they lend themselves to taking a closer look at a moment or an incident in your own history, and really kind of getting in there and taking a close look at it and really working something out, like untangling a knot. So those medicines, the serotonergic agents, they sort of can take you toward a particular part of your biography. But in contrast, ketamine, which is glutamatergic or acting in the glutamate pathway, ketamine takes you away from who you think you are. And whatever happened to you in the past, it really just doesn't matter anymore, at least for that hour. So while the serotonergic agents take you toward your story, glutamate takes you out. They're like opposite. They work in opposite directions. They're opposite tensions. So that's what I've always noticed about these different agents. I've never tried 5-MeO-DMT. I'm afraid. Oh, that's what I wanted to say. Is that these serotonergic agents, LSD, MDMA, psilocybin, they are dangerous for people who are bipolar. They can be too stimulating and can result in all kinds of terrible psychiatric consequences. So that frightens me. But in contrast, ketamine is relatively safe to use for people with bipolar depression. As I said earlier, if you combine ketamine with a mood stabilizing agent, that combination together, it can be really effective. So ketamine has different uses than those other medicines. And as I said, all of the medicines each one has a different use and a different application. And I can't wait until we get to the future when all these different medicines are available and all part of the psychotherapist toolkit. And then we can choose and pick the correct medicine for the job. Because right now, all we have is this monkey wrench. We have ketamine, and we're trying to use it for everything. And that's nuts. It's really not well suited to PTSD or anxiety. It really is ketamine is really well suited to chronic, severe, and debilitating depression. That's really what it's good at, organic depression. And so I wish we had access to other tools. There's no doubt in my mind that MDMA is clearly the superior tool for treating PTSD. There's all kinds of other work that LSD really lends itself to. There's other work that psilocybin lends itself to. So I just hope that I live long enough and that coronavirus doesn't get me. I hope that I live long enough to see the day where we can really use the right tool for the job.
That's beautiful. Thank you. I really like that, the way you described how serotonergic compounds have you go towards the problem, whereas glutamatergic takes you away. And so I guess I'll get back to a sciencey question that came up that kind of bridges that, because there was a paper that came out of UC Davis showing a common intracellular signaling pathway that's initiated by both serotonergic and glutamatergic psychedelics. So they looked at ketamine, they looked at DOI and DMT and LSD, and all kind of converged on a similar pathway to induce neuroplasticity. And so along that vein, like, how does the neuroplasticity of ketamine compare to the classic psychedelics in terms of mechanism and end result?
Great question. I don't know. I'm not a neuroscientist by training. So maybe, do you have a hypothesis?
I don't know that I necessarily have a hypothesis other than some aspects of the serotonergic system. The study I'm looking at, I did want to have a group where we were going to be looking at both ketamine and psilocybin together and how that affects expectation and visual perception. And it was really hard to try to design a study that could be blinded, where the route of administration is different. So I'd have to have a whole bunch of things where I give them an injectable placebo and an oral compound, or an oral placebo and an injectable compound. Like, what was the right way? Like, you know, I couldn't do like capsule ketamine and capsule psilocybin, you know, so I was like, how am I, the study design, the complications of the study design so that they wouldn't really know what was going on was really tricky. So I think it would have to be open label, but I think it would be something like that, where you're trying to directly compare common neurological mechanism with two different compounds that are activating different receptor systems.
So Jessica, offline, I would love to help you with the study design of that. I have some thoughts on how you could make that work.
Yeah, that'd be great, because I think that, you know, because there is kind of this glutamate problem in terms of understanding this sort of visual perception task that we're doing, but no one's looked at serotonin. And to be able to directly compare them would be really powerful, just for that whole field of visual neuroscience, but also for, I think, psychedelic therapy as well. Yeah,
that sounds fascinating. Well, just to totally nerd out for a second, the thing is, there's a couple things that are worth noting. So first of all, we scientists think that the glutamate pathway is probably the biggest contributor to understanding ketamine's experience. But in reality, when you put a little ketamine in, it actually binds to receptors in a whole bunch of different pathways. Glutamate, serotonin, dopamine, opioid, and acetylcholine at the very least. So it's hard to sort of parse out. You know what it is? I think about it like a piano. I think that ketamine is not just playing a single note, but rather that it's playing a chord, and that the chord is beautiful, and that it's, you know, you're playing a chord up and down the piano, and that it's maybe the interaction of these different pathways and their effects that is what creates this beautiful and powerful experience. So I think it's a mistake to just sort of, I think it's an oversimplification to say this is this one and this one is in a different category. That said, neuroplasticity is a phenomenon that could be accomplished in a number of different ways at the cellular level, but also at the regional and network level. And so we'd have to parse all that out in order to have this conversation. And I think that's the limit of my understanding of this. But as I said, you know, I'm not a neuroscientist. I'm a psychologist, and what I'm interested in is what I can observe in patients, in individual human patients who are suffering. So I have to be honest, I actually don't care very much about understanding how ketamine does what it does. I'm going to leave that to the neuroscientists to figure that out.
Okay.
But it's like, I don't need to be a mechanic to understand, to know that my car is driving or not driving, you know? And so I don't really need to know what's happening under the hood. I'll leave that to someone else who has more sophisticated knowledge and interest than I have. But the part that interests me is the patient shows up or gets referred to me, and says, I want to kill myself. And then my job is to figure out, okay, what tools are available to me to try to be helpful to this one person right now. And kind of the assortment of interventions and ideas that I have to offer that includes therapy and ketamine and a medication referral and a medical workup. And then we get into the behavioral things, sleep schedule, exercise, meditation. Which of these skills can I teach? How can I support the person to do these things? Where do I want to start? So that's really what my actual work looks like. And I enjoy that. So I'm going to leave it to you all and get back to me on exactly how it all works. I don't know.
All right, we'll put a pin in that, and hopefully more mechanistic research comes out. Okay, so two questions. I'm going to just lump them together because one is, can ketamine be microdose, and can you overdose on ketamine?
Can ketamine be microdosed? That's a really interesting question. So we don't, in the ketamine world, we don't ever call it microdosing. There is some evidence that came out of the lab of Angelo D. Gioannis in Australia that ketamine in very low doses, like as low as 20 milligrams orally, which is only 40% bioavailable to begin with, it might be helpful for some people in managing depression. So that would be sort of equivalent to a microdose, but we don't ever call it that. We just call it ultra low dose ketamine treatment. But anyway, there is evidence that ketamine in different dose ranges is helpful to different folks. And as I said earlier, my idea is to always give people the least amount of neuromodulating chemicals that you can possibly give, because I don't think you should be playing around with your neurotransmitters unless there's a compelling reason to do that. But in any case, so microdosing isn't really a thing in ketamine, but low dose therapeutic strategies is a thing. And so, you know, you start low and then you kind of work your way up until you get the result that you're hoping for. I should add, while we're talking about this, that ketamine treatment, even when it's optimal, is only 70% effective. And so that means that it's helpful for roughly 2/3 of people who try it, and really just not helpful, or we're barking up the wrong tree, for about 1/3 of people who are really depressed. So it doesn't work for everyone, and I think that's important to note. Okay, then the other question was, what was the other half of the question?
Whether you can overdose on ketamine.
Oh, no, probably no. I'll tell you a story about this. A couple things. First of all, ketamine is quite dangerous if you mix it with other chemicals, particularly alcohol, which magnifies ketamine's effect and the potential for respiratory distress or respiratory depression. And benzodiazepines are a potent mitigator of ketamine. So those things fight with each other, or they compete. But anyway, you know, everybody had their underwear in a knot in the ketamine community about, you know, is it okay to give patients 90 or 100 milligrams of ketamine? And I thought this was just stupid. Like, I just thought it was they're giving hundreds or up to, 1,000 milligrams of ketamine in a surgical situation. And so I knew that. That's of course in a tightly supervised setting, but nonetheless. And I knew from doing my dissertation that there was a case of a patient who got 10 times the amount of ketamine they were supposed to get. They were supposed to get 130 milligrams, but they got 1,300 by mistake. The nurse had made an error, and the patient lived. So that, clued me to the fact that ketamine overdose was probably not a huge concern, at least not in a hospital. But then I found an anesthesiologist whose name is Fernando Cantu, and he was doing something called ketamine coma in Mexico for some of his patients with really severe refractory pain syndrome, CRPS. So I was following his research, and when I heard about what he was actually doing, I decided to fly him up to California. I hunted this guy down. I persistently called and basically harassed this poor man. I stalked him until I got him to talk to me and got him to come to California for a Kriya conference. I think it was 2016. And I knew what he was going to say before he said it because I had read his papers. But anyway, he got up there. Dr. Cantu came from Mexico and described ketamine coma for pain patients. So this is 5 days of continuous ketamine IV in an ICU surgical department for pain. And he revealed that he had given 17,000 milligrams of ketamine in a 5-day period to some of his pain patients. Dude, that's 17 grams of ketamine. That's a lot of ketamine. And the patient didn't die. In fact, he did it. He had 9 patients, and I think at least 5 of them were significantly improved for pain. Anyway, he got up there and he gave this very serious talk, and you could have heard a pin drop when he finished his talk, because I knew what he was going to say. And at that point, it just was stupid for these therapists to be fighting over whether there was a difference between 90 milligrams or 110 for a therapeutic reason. It just, the perspective shifted. So anyway, that was a very significant contribution to the field of ketamine. So to your question, can you overdose on pure ketamine? Probably not, particularly if you're being supervised. You could definitely hurt yourself if you weren't being supervised. The place where people get into trouble is actually not with pure ketamine, but rather with things that are either they're doing a combination, or some people are doing really stupid stuff, like taking ketamine and cocaine together. Don't do that. That's a bad idea. Or they're getting materials that they think is ketamine, but they failed to test it and it gets tainted, and that'll kill you too. So there are all kinds of bad things that can happen, but the medically pure ketamine is probably pretty safe.
Okay, awesome. Thank you. Let's see. Do you have time for a few more questions?
I'm fine, yeah.
Okay. This one seems kind of interesting because there's a lot of these analogs out there that also have dissociative properties. So what do you think of some of those in terms of exploring them for therapeutic applications?
Yeah, I know all about them.
Okay.
Yeah. Okay, so the analogs that I'm aware of, the ones that come to mind are methoxetamine, MXE, deschloroketamine, DCK, desoxyketamine, DOK, and deschlorofluoroketamine, DCFK. And so we took a look at some of these. Actually, a research lab in Pennsylvania also took a look at these because they were hoping to find a derivative that they could patent and sell for the treatment of depression. And remarkably, we couldn't find anything that works as well as ketamine, just plain ketamine. So I think that's a no-go. I myself have tried methoxetamine a couple of times. I made a terrible mistake. I had acquired some methoxetamine a number of years ago from a research lab, and we didn't know how to dose it, so we just dosed it the same as regular ketamine, not realizing that it was 3 times as potent. What I mean is it has a binding affinity that's 3 times as high as ketamine, so it has the effect of 3 times as much, is what I'm trying to say. But we didn't know that. Nobody knew that at that time. I remember this vividly. I took what I think was 100 milligrams of methoxetamine, and I have never been so freaking high in my life. It was terrifying. And I had a really lovely friend who was sitting for me that day, and he practically had to peel me off the ceiling. It was a terrible experience. But anyway, so this was many years ago. But even as a ketamine expert, it's easy to make a mistake. So all of that is to say that I'm not a big fan of the other derivatives. All of them are longer lasting than ketamine. And as far as I know, none of them to date appear to have more antidepressant effect than ketamine.
Great, thank you. Does the efficacy of ketamine-assisted therapies and other psychedelic-assisted therapies differ between patients who are naive to psychedelics or ketamine to patients who have prior experience?
What a wonderful question. I don't know that that's ever been formally studied, but I would say no. I would say the thing that makes, just based on my own experience over the last 18 years, I would say that the best predictor of successful treatment is a couple things. Number one, a good chemistry between the therapist or the provider and the client. So the relationship is really a critical variable, and different people click with different therapists, and that's fine. And there's all different styles of therapy, and that's fine too. That's part of it. Part of it is the relationship variable. The other part of it that's really critical is getting the right dose, and not dosing too light, because then that's not going to be robust, but not dosing too heavy-handed. One of my concerns about the underground guides is that a lot of them are so enamored with psychedelic experience that they overdose the patients or overdose the clients and shoot them too far out. with inadequate preparation, and then people come back and they're terrified. They had difficult experience. They were in over their heads. Anyway, what I'm trying to say is the nature of the relationship and being sophisticated enough and experienced enough as a ketamine provider to choose an appropriate dose. Those are the two things that correlate the most with a successful ketamine treatment. I don't think it has anything to do with whether or not the client is medicine naive.
Thank you. I know you have a bias towards ketamine, but this question...
I didn't make that clear.
So this question is asking, what nature of ketamine makes it better suited to spiritual endeavors compared to other psychedelics?
Well, I don't know that it is. I'm in love with ketamine because I find it therapeutically helpful. It makes me feel better and helps me, be functional and live a normal life. So that's the big appeal for me. And so, that has caused me to study it, in great depth. But I'm not sure that it's a superior tool for self-exploration. It helps that it's legal, or it's legal for some people some of the time. So that, that opens the door to some interesting research and also to, using it more broadly. I really think that different medicine is well suited to different people. And, I like this one because it's a good fit for my hardware and for my needs, but I don't know that it's superior any other time. What ketamine does that's sort of unique is that, as I said, it's very expansive, and it takes you away from who you think you are. And that can be very disorienting if you're not adequately prepared. But it can also be a very enlightening and enlivening experience to have the shift in perspective where you realize that you and your problems are just like a grain of sand on the beach of humanity. And that can open things up and open up some interesting conversations. I do think it lends itself nicely to personal exploration and spiritual growth. But again, we have to be really mindful of all of the legal constraints.
Thank you. This question is related to bioavailability, and why does the bioavailability drop so low for intranasal versus IV or IM? So intravascular or intramuscular.
Yeah. First of all, I'm totally stoked that we got a question about bioavailability. Somebody was listening. That's great. Good work. Okay, again, I'm not a medical professional, so I can just tell you my understanding of it. But basically, there's a limit to how much you can absorb through the capillaries in your nose. And they get the capillaries in your nose get clogged up and kind of like saturated, and then they like constrict, and then they don't like absorb anymore. And so that's why when you put ketamine up your nose, whether it's Esketamine nasal spray that was prescribed for you or any other possible situation, you just kind of tap out, and there's you kind of reach the limit of how much you can absorb on that particular day. And it's not only related to your nose and how your nose is built and the physiology of your nose, but it's also related to whether or not you have allergies and what the pollen count is that day, and whether you had any dairy, because some people their mucus gets thicker when they have dairy. There's all these factors. So putting ketamine up your nose, in my opinion, is a waste of good ketamine, because it's only 40% bioavailable. For God's sake, do the math. And then with respect to putting it into your mouth, the vasculature in your gums and under your tongue is tiny and not great at absorbing, and so that's why the bioavailability in your mouth is low. Yeah, that's what I know about that. And then if you swallow it, then you're done for, because once you start swallowing ketamine, the acidity of your stomach and the digestive enzymes start breaking it down before it can get into the bloodstream, and then the bioavailability drops to like 25%. Interestingly, if you swallow ketamine, liquid ketamine, so you're not holding it in your mouth, but rather putting it straight into the digestive system, liquid ketamine works well for pain and pain management, but doesn't appear to work well for depression. So that would suggest that ketamine, our interpretation of that is that ketamine is active in different pathways, and that the ketamine metabolites are active in the opioid pathway, which is why it works for pain, but the metabolites are not as useful in the glutamate pathway or in treating depression. The idea here being that ketamine is doing more than one thing. So don't drink your ketamine. That's, again, that's a waste of good ketamine. You're breaking my heart. Don't do that.
Okay, let's see. So this question, let's see. So it's related to the clinical dosing frequency of 6 sessions over 2 weeks under supervision. Has that ever been associated with things like liver toxicity? And, you know, also, can you just expand on what are the physical and biological side effects of using ketamine?
Oh, I'm so glad you asked that. Thank you for that question. So probably 6 exposures to ketamine is probably not going to cause a problem for anybody. That's not very much. But when you get into longer term ketamine exposure, there are a number of problems. Let me think here. I'm trying to think if I have a slide I can show you about this. Oh, we only have a few minutes. I'll just answer off the top of my head. Well, the problem that I'm concerned about the most is cystitis. Cystitis is the technical term for irritation and pain and dysfunction of the kidneys and bladder. And too much ketamine exposure clearly leads to ketamine-induced cystitis that causes people to have terrible pain and difficulty with urination. And as therapeutic ketamine has gotten more popular and more well-known, we're hearing more and more about this. So I think that's something we should all be concerned about. It's not clear when that kicks in, and it's probably different for different people. And it's a small percentage of people who get it, but it can be really debilitating if you're one of those people. So that said, there's a number of side effects of ketamine, some that are, you know, not life-threatening and some that are pretty significant. But the common side effects of ketamine, recreational ketamine or ketamine treatment, include nausea, headaches, changes in vision, twitching or muscular contraction. Let's see what else. Cystitis, we talked about that, and a couple of other things. Those are obviously not life-threatening and can be worked around or worked through. I have seen 2 medical emergencies in my career, both in the early part of my career. One patient who had a seizure, and another patient who had a loss of airway, wasn't breathing hard enough to push air through. And, you know, thank God there was medical professionals on hand who were able to intervene and handle these things appropriately. But I'll tell you, that put the fear of God into me about, you know, about not using this tool in a casual way or outside of a safe container.
Are you aware of people that are administering ketamine IV or IM at home?
No.
Okay, so people that sort of self-medicate, are they're doing intranasal or oral?
No, most people who are working with ketamine on their own are getting custom compounded lozenges that are made for them at a compounding pharmacy in their state and that are shipped to them, and that they're in an agreement with their prescriber and also their therapist about how and when they use the lozenges and are using it according to the schedule, and they're logging that. It's all pretty structured, but lozenges is the primary way that it's used at home.
Okay, I guess because we're about out of time, I'll ask one final question. And looking towards the future, what does your ideal ketamine clinic look like?
Ooh, I love this question. Well, there's so much to say about what's coming in the future. But in terms of an ideal ketamine clinic, I would love to have a space that had integrative services, massage therapy, ketamine, psychotherapy, maybe acupuncture, for sure, and a really excellent organic chef, and maybe a space to do arts, and maybe a place to dance, and a really awesome sound system for really great music. I would want to have all of that, and I would want it to be super comfortable and homey. I would want people to be safe, and I would want the place to be swarming with medical and mental health professionals who were cool and casual and who had a lot of skills, but who were personable and not too stuffy. So that's what I'd like to see going forward. And with an emphasis on the food though, because I don't know if I mentioned that I don't cook. So I need someone to like feed me.
That's wonderful. Well, thank you so much for all of that. And thank you for sharing your time and your expertise with us. And thank you everyone for joining and for your great questions, and look forward to maybe doing more in this future. I'll follow up with you about potential questions about designing a study to look at ketamine and psilocybin together and how that would be dosed in a blinded way. I'd be really excited to continue that. And just thank you everyone, and have a good rest of your week and weekend. All right, bye. Thank you, Raquel. Bye.